All right. So obstetrics. Okay, so we're gonna with obstetrics. It's care for patients with pre-hospital conditions involving reproductive organs are not necessarily always common. All these types of conditions require that for us to be the most professional, safe, and effective care by the paramedic. Knowledge and skills practiced in the laboratory setting, particularly out of hospital childbirth, help the student maintain professionalism, understand these uncommon emergency care situations, and support the patient as they seek definitive care to the receiving facility. Just out of curiosity, has anyone had the pleasure of playing catch out in the field? It's kind of an interesting thing. I showed up late to one, but that was about it. So, but yeah, mainly a lot of my live births were in L&D and stuff. But what was really cool is the our OB, at least at County Phoenix, they were like, "Oh, you're a paramedic student? Get up in here, like, feel this thing." So it was kind of cool. It was very interesting, very messy, very messy. And if you guys have girlfriends or wives and whatnot, and you've gone through your childhood, you can imagine and see how that it's pretty messy. But thankfully, all the births that I've been involved with went okay. But yeah, definitely there can be some issues that spring about. So what are we going to do? We're going to definitely identify some female anatomy. We're going to discuss the process of menstruation and menopause. And then we're going to describe the traumatic causes of abdominal pain in females, such as vaginal bleeding and sexual assault. All right. All right, so as a review, the reproductive system includes your ovaries, your fallopian tubes, your uterus, your vagina, external genitalia, your mammary glands. They lie within the pelvic cavity, and they're protected by the pelvis and held. Two other ligaments hold the ovarian arteries and veins, and the nerves that are placed within the suspensory ligament. Each ovary has a dense outer portion called the cortex and the loose inner portion called the medulla. Inside are multiple small pockets, each containing an oocyte and premature egg. The fallopian tubes are ducts to the ovaries. Each tube is located along the superior margin of the board ligaments. Each one opens into a peritoneal cavity and receive the ripened oocyte. There's space between the ovary and the opening of the fallopian tube. Once the oocyte has been released from the ovary, it free floats in the abdominal cavity. The fallopian tubes have small cilia on their terminal ends that create small waves. The waves pull the oocyte into the opening of the fallopian tube. Once inside the tube, the oocyte is transported by the cilia, contractions in the tube, and towards the uterus. The oocyte can ripen and either ovary therefore enter the uterus on each side. Am I going too fast for you guys? If you guys have any questions, I mean, we are a small group, so like feel free to just just go ahead and like verbally say something, because I don't have the chat bar in front of me. So just go ahead and just pop up and say something, and we'll be more than happy to answer your question. The uterus is roughly the size of the shape of a pear. Is oriented in the pelvic cavity with the fundus. Remember thinking about that, like fundus massage, especially after that birth. Directed upward into the anterior. The inferior portion, which is the cervix, is the opening through which the menstrual blood will be passed in the event of an oocyte if it's not fertilized. The cervix is angled toward the woman's posterior sacrum. The cervix is also an opening slightly smaller than the end of a pencil, and the uterus is held in place by 3 ligaments. The vagina, also known as the birth canal, is the internal pathway of the external female genitalia. The vagina will stretch gradually from birth for a baby. The walls of the vagina secrete substances that protect the developing fetus. It becomes acidic during pregnancy, and the acidity prevents bacteria from growing that might enter the uterus. The perineum is the area of the external female genitalia that is between the rectum and the vaginal opening. In some cases during delivery, this is cut to allow for delivery of the baby's head to prevent some tearing. The mammary glands, or the breasts of the female, are an organ for production of milk. Female breasts begin to develop during puberty, which is ages 10 through 13, and under the effects of estrogen and progesterone. Each breast has up to 15 to 20 glandular lobes, which have left-filtrous ducts. Each duct has a secretory sacs called the alveoli that secrete milk during nursing. Menstruation is normal. It's a periodic discharge from the uterus of blood tissue, approximately 25 to 60 cc's. The cycle lasts roughly 28 days, and it occurs from puberty to menopause. So when ovulation occurs, by the fourth prenatal month, the ovaries contain about roughly 5 million cells. Of these, oocytes develop, and oocytes are immature cells which can develop into the fetus. At birth, there are about roughly 2 million in primary oocytes. Only 400 are eventually released from the ovaries. Wow, it's crazy. All right. I want to just take a quick pause, and just kind of maybe ask some housekeeping questions. So I'm going to be your instructor tomorrow. And did anyone have any questions in regards to how your test is going to be, or if you feel like you're in the right refresher course or anything like that? Because when I taught an EMT course just over the weekend, they had some similar things. So since this is the medic refresher, I wanted to try to find out if there's any questions that I could answer, or I can get answered while we're on our lunch break.
I actually took this 2 years ago as a refresher through EMS University, so I'm kind of aware of how it works.
Oh, great.
Yep.
If you could just give us what your experience then was like, and then in terms of confirming that it is 3 days, and we do PowerPoints, and just kind of go over the test, that would be awesome.
I took it. I was actually in Iraq at the time, and I had really bad internet, but it pushed through it. It was actually 4 days at the time.
Okay.
When I took it, and it was pretty seamless. PowerPoints were good, and all that stuff is online, so you can actually do your own studying off of it. And the test was it was difficult. It's a very difficult refresher test.
Mm-hmm. And the test turned on roughly at a certain time. So tomorrow it's going to turn on 1500 Pacific time. Is that the same kind of deal that you had experience with?
Yes, sir.
Okay, cool. And then it was roughly 150 questions?
I believe it was 100.
It was 100. Okay.
I think. It's been 2 years.
Yeah, for sure. It could be either 100 or 150. As your classmate had mentioned, it is a pretty tough exam. I personally have not taken it, but I have heard that it's pretty tough. The reason why it's tough is that I believe it pulls questions from a 500 bank test bank. So, and it's all randomized and everything. So, a good portion of where you're going to actually go and succeed on the test is from not only looking at our PowerPoints today and asking me questions, but furthermore, all the material that is located in your student portal. I believe you guys have to actually complete certain assignments. Is that correct?
Yes, that's correct. There's a few quizzes that we have to complete, and then we have to make sure that every box has been checked on the portal for you to get the certification.
Yeah, exactly. So make sure you fill out all that housekeeping stuff in regards to, your certs, your AHA cards, blah, 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 the policy and procedures agreement for taking the course. In addition to completing those quizzes, I hear that you can take those quizzes over and over as many times as you like. And those are very, very similar questions to which your final exam will be based off of. And once you go and you complete the various little lesson assignments, then that goes and that qualifies you to go and take that final exam. So make sure you guys are looking over that kind of stuff. Go ahead.
Are the slides that we're looking at now, these are available for us to review in our own time as well?
Yes, they are.
Okay.
Yeah. You roughly have 24 hours or maybe even a little bit more of actually having to stay in these chat rooms and be on these slideshows. I know it sucks. I get it. But that's part of the requirement because it is a 48-hour refresher. So that's how we technically get away with it, and that's how this is actually sponsored or approved by the National Registry. So you guys have to stay in, and everything. So, but if this is truly boring, then I really recommend that you guys go look into student files and look at some of those other things. Is someone okay? I think someone's kind of breathing a little heavy there. I don't know who it was, but okay. Oh, here we go again. All right, so hormones affecting ovulation, FSH. It's a follicle stimulating hormone, and then LH, luteinizing hormone, stimulate the follicles to ripen. The follicle forms a bump on the surface of the ovary. This ripened follicle is called a Gaffian follicle. The follicle ripens faster than it can be accommodated by the ovarian wall. The follicle swells and ruptures through the wall of the ovary. It enters in the space between the ovary and the fallopian tube. The oocyte moves out of the follicle and floats into the fallopian tube. And this is ovulation. After ovulation of the follicle is transformed into the granular structure, the corpus luteum, containing the progesterone and estrogen. If the oocyte is fertilized, it begins to secrete chronic gonadotropin. These hormones stabilize the corpus luteum so that it continues to release the hormones that prevent menstruation from occurring, which would flush out the fertilized oocyte. If the oocyte is not fertilized in the corpus luteum, disintegrates, and the level of the progesterone and estrogen drops when the menstruation occurs. In the interim, the hormones from the pituitary gland are preparing for the interior of the uterus and implantation of the oocyte, which will now be the ovule. The walls of the uterus are thickened and become lined with a rich layer of blood vessels from the ovum to the latch of the onto. If the ovum is fertilized, it finds a prime location, latches on, then begins from. If not, the uterine contracts and evacuated, the cyst starts over again. All right. Has anyone ever come across any like miscarriages?
Negative.
No.
No.
Yeah. Yeah, I found it interesting because I worked on a Native American community, and it was pretty rural out there. Even though the city was roughly anywhere from 30 to 40 minutes of a drive in town to your closest appropriate hospital. But like they you know, they really, you know, trusted us in terms of the EMS company that we were. And there was, I just remember finding it a bit unusual when I would show up, and you know, at this time I was an EMT, but they would go and they would show me their miscarried or product of conception in a red Dixie cup and just be like, this is what came out of me. Or they would go and bring me to the restroom and be like, this is what happened. And obviously the, you know, the patient was miscarrying and stuff. You know, being a male, not dealing with it, I don't have any sisters or anything like that. And um, I don't know, like that kind of stuff I didn't really pay attention to, but it was kind of, it was a little disturbing at first, but after a while, you know, you just kind of get used to everything, just like it is with an EMS. But now working in the ER, I mean, there's women that miscarry every day. I mean, um, it's always sad, you know, because they're usually pretty upset about, you know, whatever has gone on. But I just didn't think that it was that prevalent. And stuff. But when you kind of come across these things, you know, it's always good to have like a good demeanor, you know, be very respectful. Typically, I know it's a little bit different, like when you're on the ride, especially if the patient is pregnant, you do have to take a peek and stuff. But, and if you're an all male crew, well, then, you know, the female just kind of feels probably a little awkward. But, um, you know, it's a sensitive topic for these particular patients. So, um, yeah, but yeah, I was just curious if anyone had any experience with that or felt it similar. Let's see. So be aware of your pelvic inflammatory diseases. Some symptoms of it can be lower abdominal pain, low-grade fever, vaginal discharge. Mm. Whenever you have any suspicion of some vaginal bleeding, feel free to go ahead and like place like a chuck under them if you have them on your ambo or wherever you are. So in reference to that pelvic inflamed disease, you could see the inflamed, like that's what an inflamed ovary will look like, and an inflamed fallopian tube compared to the left side, which would be your normal structure. So yeah, just imagine that as like a lot of like inflammation going on in there. That would really suck. So the ruptured ovarian cyst is obviously a gynecological emergency. It can cause a severe internal hemorrhaging. The cyst can form from the surface of the ovary and usually is filled with fluid. It causes abdominal pain and a rapid expansion within that lower abdominal cavity. It also causes torsion of the ovarian pedicule, and that lead to ischemia of the ovary. The cyst can also form a hemorrhage inside the corpus luteum. Most ruptures occur about 1 week prior to the onset of menstruation. So keep that in the back of your mind when you are going through your OPQRST and your sample. When you obtain that last menstrual period, kind of figure that out in terms of where they are in their cycle. You might present with some vaginal bleeding, um, one-sided lower quadrant pain, also signs of internal abdominal bleeding. That's pretty gnarly right there. um, looking at that ovarian cyst, wow, looks painful. Definitely don't want to experience that. So watch out. I mean, with these cysties, both sexes can get these cysties, but it's much more common in women due to the short length of their urethra. What are some of the common signs and symptoms? Frequency in wanting to urinate, only producing a small amount of urine. It might have some chills, fever, lower abdominal pain, some strong smelling urine, burning on urination. There could also be some pressure that gets built up, caused by the indwelling urinary catheters, which are common in nursing homes. So we need to take out from your sniffs. And just in general, UTIs are fairly common within females. It can be simply treated with some antibiotics. Usually, once the antibiotics is on board, usually within a day, symptoms relieve. And there are some over-the-counter medications. So this is like some severe pain that happens during menstruation. The dysmenorrhea, headache, nausea, diarrhea. A common medication that your patients might be taking before this would be Advil or Motrin. There can also be some an infection, inflammation, or IUDs that can go and cause this. The middle Schimmer's for some middle pain, I guess that's what it means in German, may occur from the rupture of the Graafilen follicle, which is the right or left lower quadrant pain lasting roughly 24 to 36 hours. It occurs in the middle of the menstrual cycle after ovulation. Patient might have slight vaginal bleeding, low-grade fever. It is not life-threatening, but it is indicative of a more serious complication. Patients should seek medical attention to rule out other causes, such as, of course, our infamous ectopic pregnancy and appendicitis. Endometrius is an inflammation of the uterine lining caused by an infection, retaining uterine content, retain placental tissues that may affect the uterus or the fallopian tubes. If untreated, can lead to sterility, sepsis, and death. So some signs and symptoms: vaginal discharge, fever, low abdominal pain. So again, endometrius is a gynecological condition categorized by abnormal growth of endometrial tissue outside of the uterus. Fragments of the endometrium may be pushed out of the uterus into the fallopian tubes and into the abdomen during menstruation. The fragments attach to other structures and begin to grow. We might have bleeding within the cysts that causes pain. Women who have not had children have endometrius more often. That's an interesting fact. I didn't know that. Endometrius roughly occurs within women around the age of 37. Seems like your usual types of signs and symptoms. Ectopic pregnancy. Number one thing that we always need to take in consideration when we have a female within the childbearing ages to go and rule out, right? It can be, again, like a dire medical emergency. It occurs 1 out of every 200 pregnancies. Causes would be a pelvic inflammatory disease, adhesions from previous surgeries, tubular litigation, previous ectopic pregnancies, multiple sexual partners can lead to some ectopic pregnancies. It's basically is when one in which the fetus develops outside of the uterus. It might develop, usually it develops within the fallopian tube, but it also can happen in the ovary, the cervix, or even the abdominal cavity. Most ectopic pregnancies are discovered by the 2nd month of pregnancy, when the developing fetus becomes too large for the structure of where it was implanted. Majority of women do not know that they are pregnant, that they may have a negative pregnancy test. Since the fetus does not implant in the uterus, the patient may have had normal menstrual cycle. So, as a review, common signs and symptoms would be severe low abdominal pain, pain across the upper thighs, some spotting, pain in the shoulder, some syncope, internal hemorrhaging, shock, sepsis, and peritonitis with subsequent sepsis that may develop as slow bleeding. Treatment for this is obviously going to be at the higher level of care facility that you go to, at the hospital. So that would be, they would have to surgically remove the fetus, the placenta, and damaged tissues from the implant site. The fallopian tubes or ovaries may rupture depending on the increasing size of the fetus. And remember that patients who have had the previous ectopic pregnancies are most likely to have another one. Oh, it's some pretty serious stuff right there. Wow. Okay, so just always remember that when it comes to your vaginal bleeding, the most common source is through the menstruation. But other possible causes can be a spontaneous abortion, placental disorders, hormone imbalances, uterine growths, or pelvic inflammatory disease. So the vaginal bleeding can be life-threatening, but not all bleeding is. Remember in your samples in your OPQRSTs to ask how many pads that they're going through, and retain that information to the emergency room. Most traumatic injuries are caused by straddle injuries, blows to the perineum, and blunt force from the lower abdominal. Can also be caused by a pelvic fracture causing internal injury, abortion attempts, or even sexual assault. Sexual assaults are a crime of violence. It is estimated that 1 in 3 women will be assaulted in their lifetime, but only 15% will report it. Anyone of either gender can be sexually assaulted. First, care for the patient as you would any other patient, with an emphasis on addressing any life threats. Modifications should be made for the physical exam, privacy, and confidentiality. Paramedics should be the same sex of the victim if possible. Don't question the patient in detail about the event. Allow the patient to speak openly if they want. Record our information accurately. Be empathetic. Emotional support is very important to these types of patients. When you're dealing with their clothing, I heard from a cop that it's always best to try to put that clothing in paper bags, but I don't know if we always carry paper bags with us. But if you have PD on scene, they might. So maybe you can ask to get that. Again, the patient might be, feel very awkward and very embarrassed, very shamed, so they might want to potentially try to go and bathe, but don't allow them to do that, because when they get to the ER, they're going to want to go and grab some forensic kits that they need to do and try to minimize your disturbance to the crime scene as little as possible. Conception. All right, so the oocyte is expelled from the ovary and travels to the fallopian tube, where it meets with a traveling salesman. The sperm enters the cell membrane and the oocyte, and the cell wall immediately prevents any other sperm from entering. The nuclei of the sperm and the ovum fuse. The ovum becomes the zygote and begins a number of cell divisions that continues to travel down the fallopian tube towards the uterus. The ball of the cells becomes the morula. The morula has a layer of cells as outer wall, the trophoblasts. Once the morula rolls out of the fallopian tube, it moves down the wall of the uterus. The wall of the uterus is sticky, so the morula doesn't float around. It slides down the wall and finds a place to attach. The trophoblasts attach to the wall of the uterus and start to dig in it to make the contact with the maternal circulation. Implantation occurs within 7 days of the oocyte being fertilized. As soon as the trophoblasts implant, there is slight discharge of vaginal blood. This bleeding can be misconstrued for the female as spotting. As soon as implantation occurs, the plug begins to form with the opening of the cervix to prevent bacteria from getting in and anything from getting out. The trophoblast cells continue to develop and begin to form the placenta. The placenta is a flat, round organ that is composed of the intermeshed fetal and maternal materials. It is the organ that connects the mother to the baby and performs a number of functions during its pregnancy. O2 and CO2 diffuse through this placental membranes, maintaining homeostasis in the developing fetus. There's also glucose and other nutrients that diffuse through the placental membranes at the same time as the O2 and the CO2 diffuse. Waste and removal of the products from the fetus are diffused through the fetal blood into the maternal blood for the disposal. It becomes with hormone production, it becomes temporary endocrine gland taken in place of the corpus luteum from the ovary. It begins to produce estrogen and progesterone to maintain the levels of hormones needed to maintain during the pregnancy. The hormones stimulate change in the mother's breast, vagina, cervix, and pelvis to prepare for labor, delivery, and lactation. Placenta forms a barrier against harmful substances, although it's not a complete barrier. It provides some protection for the fetus. The placenta then goes and forms an umbilical cord. Blood flows through the fetus to the placenta through two umbilical arteries. Remember that those arteries are deoxygenated, and blood flows back to the fetus through an umbilical vein. Remember that the blood from the fetus and the mother, they do not mix. Umbilical cords can be roughly 6 to 36 inches in length. It's covered with a substance called Wharton's jelly, which constricts when it dries, cutting off the blood flow through the cord. The cord should never be pulled on. Umbilical cord showing 2 arteries and 1 vein. Fetal circulation is unique due to the fact that the fetus is in utero and not an air breather. fetal circulation adaptations are as follows. It is a ductless. A ductus venus is the continuation of the umbilical cord, which shuts most blood returning from the placenta to bypass the liver. It empties directly into the inferior vena cava. The foramen overall and the ductless intravenous allow blood to bypass the lungs of the fetus, so it's not necessarily, again, not breathing air. The foramen overall is the opening between the right atrium and the left atrium, bypassing the right ventricles. It also connects the aorta and pulmonary arteries, so blood-rich O2 from the placenta enters from the left side of the heart instead of the right. Blood that enters the left of the heart is pumped through the left ventricle, so to the head and arms. At birth, the various shunts begin to close down as soon as the neonate begins to breathe. The amniotic sac is just the fluid that surrounds and protects the developing fetus. It contains fluids that is created by the fetus secretions from the respiratory tract, skin, and urine. It contains about 1 liter of amniotic fluid in a full term. So some maternal changes in pregnancy. The uterus increases from 70 grams to 100 grams by 1,000 grams by term. The uterus triples its size by weight by the second month of pregnancy. The uterus occupies pelvic cavity and may be palpated by the 3rd month. It becomes an abdominal organ, and the fundus reaches the umbilicus by the 4th month. And during the last trimester, the uterus settles into the pelvis. Some of the changes that happen with the cervix is that it turns to a bright purplish color due to the increased blood flow. The vaginal mucosa thickens and the acidity of the vagina becomes more acidic to keep free from pathogens. If any of your wives or girlfriends were pregnant, you always knew that their bladders definitely were becoming enlarged by the uterus, and so they would have to pee so frequently. Their breasts become tender in the first few weeks of pregnancy and continues throughout. In terms of their GI tract, morning sickness and nausea are a result of high serum levels of chronic gonadotropin. The GI organs are displaced upward and laterally, making the mother more prone to heartburn and aspiration. The liver is displaced backward, upward, and to the right. So you can see as the fetus is developing, all this gets shoved out of the way. So just remember that the diaphragm does displace. Sometimes your ECG may show flat or negative T waves. Cardiac output decreases by 30% by the 34th week, and the pulse rates increase anywhere between 15 and 20. Same with your blood pressures. They can decrease anywhere from 10 to 15 millimeters per mercury. Slight edema might be seen. You're going to have increased plasma volume, which reduces the hemocrat. Leukocytes increase in number. Fibrin levels increase by 50% due to estrogen and progesterone. So there could be potential, if there is a traumatic case, lead to excessive clotting. They're going to be irritable volume and minute ventilation will increase. Respiratory rate may be normal, faster depending on the elevation of the diaphragm. and your PCO2 will decrease due to the increased respiratory rate. Remember that they're going to be gaining some weight. So roughly maybe 20 pounds, increased water retention. You're going to have an increased metabolic and caloric demand. So and make sure that they're on their prenatal vitamins. It's kind of sad sometimes to come across patients that know that they're pregnant, but they don't want to go get checked up, or they're in limbo. I mean, the best thing that I think that you can, as a provider, if you come across this, and when you ask, like, oh, what type of prenatal care are you doing and whatnot, at least steer them in the direction of going into the store and taking those prenatal vitamins and stuff. Because it just, I don't know, for whatever reason, some patients just don't want to deal with it, or they don't have the right insurance and stuff, and it's kind of sad in some way. But so now it's our assessment portion. So we want to know the length of our gestation, like when is the due date. We want to know your para and gravida, if there were any previous deliveries, and if there's any C-sections involved. What type of lifestyle does the mother have, whether it's alcohol, drugs, or smoking? Also, that prenatal care can be in that lifestyle. Any sort of infectious diseases or current illnesses, and history of any previous OB or OB problems. Eclampsia, generalized seizures. Okay. So the presence of the pain is currently, and is it labor or is it some other problem? You want to definitely know the onset. You want to know the duration of the progression over time, the location. Is there any vaginal bleeding, any rupture of any membrane? So did the water break? Current health status and prenatal care, and any allergies or medications taken within the last 4 hours. Most important hallmark question is, does the mother want to urge or bear down or have that or pass a bowel movement? That's basically indicating that a delivery may come soon. You want to identify the chief complaint, any other life threats, and keep a watch out for any imminent delivery. Of course, you want to keep up with your vital signs. In terms of assessment of the fetus, anywhere between 16 to 40 weeks, the fetal heart turns can be heard. It could be auscultated with a stethoscope, fetal scope, or a Doppler. And normal fetal tones will be anywhere between 120 and 160. Very important, if you're going and assessing these fetal heart tones, do not tell the mother that you cannot hear the heart. That will just cause a whole nother wave of panic. But you might be able to feel the fetus moving, so that'll be good. Make sure that you're keeping that SpO2 of at least 100. Transport, we get in a position of comfort, but also make sure that they're safe. So remember that there's 3 stages. The beginning of labor begins with the contractions, and that's when your cervix is dilated to roughly 10 centimeters. For us, we're not going to know that. I mean, we're not sticking our hands in there. But when my wife was giving delivery, I mean, she got checked, I don't know, like, I feel like at least 8 to 10 times. And I don't know, we had some residents, so like, they're relatively new, and 10 centimeters, I mean, and feeling that, I don't know, that's just crazy to me, but to know that it's dilated that much. But, you know, I guess they practice and that's how they get better. But just hearing that term, like, oh yeah, it's really, yeah, I think we're dilated. It's 10 centimeters. Like, oh, we're almost there. Like, I mean, yeah, no, it to me, it just seems like such a small area to cover that's how they could tell. But it really, I don't know. But of course, you know, the attendings, they felt it. And sure enough, yeah, my daughter came out like roughly 4 hours later. But that's your first stage, is when you have these beginning contractions and when you're fully dialyzed. Your second stage will be from the dilation of the cervix until when the baby is born. And the third stage is that delivery of the placenta. Oh, I guess there you go. Because when the baby's head is facing down, entering the birth canal, that's how you can feel that cervix area. Okay, so keep in mind, for first-time moms, may take up to 12 hours or longer. I know my wife was in induced labor for, I want to say, 30 hours, 30 hours or so. Yeah, I mean, what a time period. You know, like they always say, like, oh, make sure you get your rest and blah blah blah. Well, like Friday night we go in because she was she was supposedly spotting. We thought like she lost her mucus plug, and there wasn't like heavy um, liquid that followed or anything. It was just a little bit, some like thick tinge that was on her liner. And so we go in and get checked out. I'm like, oh no, not ready yet. Obviously, didn't sleep all that well. Came back home. Then we had a 2 o'clock appointment to go, a 1400 appointment to go back in. And then they were about to go and send us home again because of the technicalities of whether she was post term or whatever it was. But then when they decided to keep her, and then they induced her, and man, just like that whole process of just sleeping on that little couch and then being with her and everything, like it's nothing more than, I thought that process was the most rude and awakening portion to it than actually like dealing with the night feedings that came later with my daughter. So I don't know if you guys ever experienced that, but that birthing process was way more intense than I felt like actual, you know, taking your baby home. Um, be mindful that your contractions will start out slowly, roughly 30 seconds long to 10 minutes apart, and the closer that they get, the cervix will dilate, and then it thins out. So be aware again, like it's super important to ask like what their pairing gravida is, because if they have had previous pregnancies and also births, then you know that this birth will come a lot quicker than you might anticipate. Always listen to your patients, because especially if they've had previous deliveries. Especially those key words, the baby's coming. Be prepared. Keyword transition when you go to the second stage of labor. Get ready to play catch. Make sure you have your proper PPE on. Crowning. So just apply a little bit of pressure. I mean, you don't want that. And it's not that the baby's going to go pop per se, but you're applying that pressure so they're not moving out so fast that they go and they do extensive tearing and whatnot. So just a gentle pressure, not like pushing it back in and being like, not on my cot, definitely get it in the ER, but more so just easing it out. And that's what you're doing. You're preventing that explosive delivery. In between the contractions, they recommend maybe to pant. You want to check the umbilical cord. Make sure it's not wrapped around the neck. If the cord is wrapped too tightly to move, clamp it in 2 places and cut between the 2 clamps. The external rotation of the baby's head causes the baby's body to turn sideways in the birth canal in order for the shoulders to deliver. Once the baby has rotated, push gently against the upper and lower shoulders, and the baby should slide right out. There will be copious amounts of fluid, as I mentioned before. Remember, you want to go and suction the mouth first before the nose. M is before N. Keep the baby at the level of the vagina. Don't do anything to the cord as you wipe it off. Wiping the baby off stimulates the baby to breathe. And remember that it's covered with stuff, so make sure you wipe it off. Yeah, have you ever seen those babies, man? Like they do look great. It's crazy. And then they start to pinken up and everything. Remember your Apgar scores? So get that 1 in 5 minutes. Know the time of birth. That Apgar score, again, each category gets points between 0 and 2. Heart rate, that is over 100, gets 2. Respiratory effort with good cry is 2. Muscle tone, like they're moving, that they're able to go and find out their reflex irritability and their color. And typically your score is going to improve from at your 5-minute mark compared to your first minute mark. Now, if we're clamping the cord after it's, after a normal delivery, is roughly about 10 centimeters. You don't want to twist your cord. And make sure from when you clamp it down that 2 inches away, you put the other clamp. All right. It's pretty standard here. Remember that oxytocin causes the uterus to contract and will help slow the uterine bleeding. Massage the fundus. Remember, it feels like a grapefruit-like, and it feels weird. It feels really funny, but it does feel like a grapefruit. Definitely, there's like a mass right there. And just wait for your placenta to come out, roughly within 30 minutes. That thing will be sloshing on out. It seriously looks like that. It's pretty crazy. Remember, if there's any bleeds or anything, just to go ahead and put some gauze over it. If the peritoneum like got ripped or something, or an OB pad would be better. Remember your oxygen therapy, IV access. Of course, you already established that. You got your EKG beforehand. Fluid should be your PRN. In 2013, there was roughly 3,932,181 live births in the United States. Yeah, huge number. This distribution by age group was under 20 years of age. There were 26.5 births. Between the ages of 20 and 30, there were 87.7 out of 1,000. 30 to 34, there was 98. 35 to 39, there was 49. 40 through 44, there was roughly around 10. And 45 to 49, there was a little less than 1. And over 50, of course, less than 1. So, it is a huge range, I think the age that I've actually witnessed a pregnancy test be positive was a 13-year-old. but I know that my hospital has guidelines that we perform these pregnancy tests on the urines that we collect from anywhere from female that range from 10 through 55. So it can happen. And so just be prepared for everything. In this section, we're going to be discussing some of the complications with pregnancy in the postpartum and the antepartum periods. Some of the topics will be preeclampsia, eclampsia, placenta previa, placenta abrupto, abortion, cervicopelvic dysportion, the breech presentations from the birth, cord presentation, such as a prolapsed cord, premature birth, post-term delivery, multiple gestation, and uterine inversion. One thing that was interesting was I saw a prolapsed uterus the other day. It's kind of, this is maybe a couple months ago, kind of disgusting to see, but because it was, I think, in a 82-year-old female. She was from a sniff, but yeah, like you just see this big old pink bulge coming out. I was like, whoa, what the heck? Working in the ER has been very interesting. I don't know if you guys have had the opportunity to work there in such an environment, but yeah, it's kind of crazy some of the stuff that you come across. So even though the prolapsed uterus is not listed, but it's definitely, it kind of reminded me of either breech and then the cord prolapsing, whatever. Anyway, all right, here we go. So preeclampsia, as a refresher, it's a medical condition that develops during the second trimester of pregnancy. The seizures distinguish between eclampsia and preeclampsia. Okay, so causes will be the hypertension, any edema, headache, low uterine output, and proteins in the urine. And it occurs roughly in anywhere from 5 to 8% of all pregnancies. It's more common in women who are under 20 and over the age of 35. Risk factors could obviously be hypertension, diabetes, first pregnancy, multiple gestations. But a key factor when you discover this would be blood pressures reading roughly 140 over 90. Gestational diabetes, it's caused by the pregnancies. It occurs in roughly 4% of all pregnancies, related to mothers that have the inability to metabolize any carbohydrates, causes a transfer of glucose and fats to the fetus for storage, leading to macrosomia. Mothers will require frequent monitoring and dietary modifications, and maybe even possibly some insulin. So babies may be large due to this fetal macrosomia. The increase of the risk factors are fetal and maternal injuries. The infant is at risk for developing respiratory problems, obesity, and type 2 diabetes mellitus. Well, it looks like a big old baby, huh? So again, you can see it. The high glucose level in the mother will then go bring extra glucose to the baby, which then will cause the baby to put on some extra weight. Placenta previa, it's a normal position of the placenta. Usually it hangs low in the uterus. It's discovered by ultrasound, occurs roughly 1 in 300 pregnancies. It's associated with preterm births, increasing maternal age, and previous C-sections. May be positioned or particularly over or completely covering the opening of the cervix. When the cervix begins to dilate, the placenta begins to prematurely separate, causing bleeding and loss of circulation to the fetus, which is categorized by bright red or painless type of bleeding. You can see the various type of drawings of the actual placenta previa. Normally, I guess it's up. Here's the abnormal. Placenta asura occurs when the part of the placenta attaches abnormally to the uterus. Normally, the placenta doesn't grow into the uterine muscles. It grows on the uterine wall. When the placenta attempts to detach itself during the third stage of labor, it leads to types of severe hemorrhaging. And this may necessitate an emergency hysterectomy to control the bleeding, so the uterus is unable to contract or stop the bleeding at all. It grows in various layers of the uterus. So acerta grows in those various layers of the uterus. Incerta grows within the myometrium. And then percerta grows within actual uterus walls. Premature between 34 and the 35th week of gestation, and mothers who have the placenta acerta. This is not the best illustration, but there's the partial. There is in the medium or the middle layer, and then this total takeover. And interesting. The uterine rupture, it is a catastrophic event, may cause both fetal and maternal deaths. Occurs once in every 1,400 pregnancies. May be spontaneous or caused by trauma, may also occur at the site of the C-section. It's a sudden tearing, remember? May feel or palpate the fetal content through abdominal wall. The patient may go into active labor. That just looks all messy. Wow. Anyone ever see a C-section?
I did during my rotation in the OB, saw 2 C-sections.
Yeah.
Yeah, they're messy too.
Yeah, messy. It's crazy to see these OBGYNs just like pull this head out. It's like, and like
They look rough too. Like they look really like you're, yeah, it's like just pulling and ripping at the woman's stomach, and it's nuts.
Yeah, I mean, not only this, like you have those spreaders that are there and whatnot, but then you grab this head and you're just yanking on this thing, and it's no wonder why they got a drape. And then you had us medic students over in the corner just with our eyes like bulging out, like holy shit, like what the hell, like how do you when you're ripping this head out? It's crazy. Pretty like animalistic. I don't know, like medieval, like, but I don't know. That's just how they do it. But I guess you can also have a uterine rupture. I didn't have a uterine rupture, but and I guess this uterine rupture can occur from a C-section. The placenta abrupto, it's a partial full separation of the placenta after 20 weeks of gestation. Once the placenta abrupto happens, it can cause a fetal death. It has happened roughly once in every 400 cases or so. It's some of the things that are associated with placenta abrupto would be hypertension, preeclampsia, trauma, previous abruptions, maybe the use of medication to induce labor. You might also find maybe a rigid abdomen or absent fetal heart tones. So these abortions, these are the spontaneous abortions that I shared with you earlier. Bringing this cup full of all this, like, and because I'm in a hospital, I call it product of conception, which it technically is, but this red mush, and it's like, what the heck? But it's the termination of pregnancy before the 20th week of gestation. It's the most common frequent cause of vaginal bleeding within pregnancy. You have a complete, so all the products of the pregnancy have been passed. You have a criminal, which is performed illegally, or an incomplete, like there's tissues that are retained in the uterus that require a DNC removal. And that's common too. You know, there's other products that get caught in there and everything. So be mindful and be like, you know, well, I did pass something the previous day, but I've still been bleeding. You know, I thought it was normal, but I'm still feeling pain. Keep high suspicion that maybe there might be still products stuck in there and whatnot. So be advocate for those types of patients when you're taking them to your higher level of care. So hyperemesis gravidarum can be caused by an increase in chronic gonadal platism. Can lead to roughly GI injuries. Also has intractable nausea and vomiting during pregnancy, during dehydration or electrolyte imbalances. PEs are the leading cause of death for pregnancy due to the effects of the gravid uterus on the circulation in the lower extremities, causing a DVT, which will then migrate to the lungs. PE can also cause amniotic fluid escaping into the maternal circulation. And just keep in mind that PEs can triple during the risk of pregnancy. All right. Premature rupture of the membranes refers to spontaneous rupturing of the amniotic fluid prior to onset of a true labor. One thing that was interesting was they went and they broke my wife's sac because I guess my daughter was in a little bit of some distress. Her heart rate was just kind of going up and she just wasn't positioning well. But then it was interesting to see, like, you always hear like, oh, like the bag of water has been broken. Like there's nothing else more that they do. And you think that like delivery would be imminent. They went and they refilled it. And they basically, what they did is they put sterile saline in that uterus. They delivered it right in there. So I thought that was kind of interesting. Like, well, I thought they broke it and the baby's supposed to be coming. But actually, in the OB world, it's fairly common to go and refill that canal. And sure enough, like, I guess the baby couldn't handle all of the fluid that was in there, but with refilling it maybe 3/4 the way, she just wanted to hang out in there a little bit longer. So I don't know, it was kind of interesting. I never had heard of that before. But I mean, I guess that's why they're OBs and they do all that kind of stuff. We're just there just to kind of have an overview and play catch and make sure everything gets okay when we deliver them to the hospital.
That's crazy. I've never heard of that either.
Yeah, no, isn't that weird? Yeah. Okay. So, water's gonna get me through this whole day. All right. So premature ruptures of the membranes, again, occurs in 30% of the preterm births and is a major contributor to the prenatal morbidity, leads to a high risk of the cord prolapse and infection. So I guess there can be excessive fluid. And it looks like they're going in there, retract some fluid. Both are considered a delivery conditions caused when the delivery is unable to continue because of a part of the baby's body is too large to pass through the pelvic opening. Cephalopelvic disproportion indicates that the baby's head is simply too large to pass through the pelvis. With a cephalopelvic disproportion, the vaginal delivery immediately becomes an emergency C-section. A shoulder dystocia is a little more complex because the baby's head has delivered and the shoulder is wedged between the pelvis and the vaginal opening. With a shoulder dystocia, the baby's shoulder may have to be fractured to facilitate delivery since the cord is usually compressed during the delivery. The cord prolapse or cord presentation. It's a prolapse of the umbilical cord that occurs when the cord exits the uterus before the baby does. It occurs when the cervix begins to dilate and the baby is not in the head down position in the uterus. May be caused by in the presence of twins, or just maybe a very long cord. The treatment of the cord is to always keep it wet if it's presenting, and deliver by C-section. So I guess there's various types of occult prolapse. And then there's the prolapse of the head, and then the complete prolapse. The uterine inversion. Uterine inversion is the prolapse occurs when it's turned inside out and maybe prior complete. So this is what I saw the other day to that demented patient. It was crazy. I mean, like, you're dealing with obviously a geriatric patient, and she doesn't really know what's going on and why she was there. Kind of feel bad for her, but you just go and you just take a look, and you just see this big old pink bulge just flipped out. And one of our docs was just kind of like showing us. Luckily, the ER I work at, they're pretty awesome doctors. We get a lot of like unusual stuff. I mean, we're a medical facility for the most part because we intake STEMIs and strokes, but and just like a mile up the street is General Hospital or LA County, and that's where all the level 1 traumas go. But sometimes we have homey like walk-ins of gunshot wounds, this, that, and the other. But the doctors there, they're always like, they like to teach their staff, and we are a teaching hospital as well, so they go and they show us everything that they can. It's pretty interesting. But yeah, it is crazy just to see this big old like pink mass just protruding out of this vagina. So could be some bleeding that goes on with it. And as you can see here, I didn't actually see them place it back in, but I guess that's how you do it. With postpartum pregnancy, any postpartum pregnancy is defined as a pregnancy that continues past the 42nd week. Risk of fetal malnutrition, meconium aspiration, the placenta start aging as the starts to fail. Remember that prematurely a child was born before 37 weeks of gestation. There can be some birth defects and some hypothermia and respiratory failure with immature lungs with those types of patients. I think twins occur, roughly 1 in 80 to 90 deliveries. I think some other things to think about are, parents that are utilizing those fertility drugs or even fertility procedures and stuff. So then, you have a higher possibility of having more fetuses. With these multiple births, you can have a breech birth. My wife's best friend, she's actually a triplet. It's crazy because they look all alike. They have very similar features in their with the way that they're built and their facial. But I never really knew anybody, It's kind of crazy. But to see like where they all possibly fit, it's kind of insane. And I guess you have Octomom too. That's down here. I thought, she came out in the news. I think what was it, like 2009 or something, and then she kind of came back in the news like recently. It's typical LA, I guess, for you. So with these breech births, although it's technically not a pre-delivery complication, delivery of a breech birth can be difficult, and it's best done in the hospital where C-section can be performed if necessary. 3 types of these breech births are the frank, the foot-long, and the complete. Common are with twins due to the positioning of the uterus. So this is where you don't have any of the extremities protruding outward. So that's a frank. A complete is where, again, no extremities being low, but the head is at the top, and the footling is when the foot is protruding outward. Okay, so I had a trifecta one time where, oh man, it was very interesting. It was that late call that hit out early in the morning, but it's because this guy was on a bender, and we get a call for an MVA in which it was two cars chasing each other. One was trying to escape from her boyfriend, and he had a gun, and he was shooting at her in the car, and they both like flipped over in the canal or something. And this patient was 22 weeks pregnant. So my partner and I, we looked at each other, and obviously, like we shipped her out via air because we just wanted to make sure. And it was roughly at that time, it was by ground. It was at least probably 15 minutes to get to the closest appropriate trauma center. But we were just like, well, and she had luckily she only had a gunshot wound, at least an entrance wound in an exit in her right arm and whatnot. So, but she was a GSW patient, 22 weeks pregnant, and involved in a multi-vehicle accident. It's kind of crazy. So it was the craziest little trifecta there. Anyone have anything similar? Guess not. Okay. Well, I mean, a trauma does occur roughly 6 to 7% of the pregnant females, and is one of the leading causes of maternal death, with minor trauma being anywhere between 1 and 3%. With life-threatening injury to the mother, the fetal death does occur, and that happens roughly 41%. MVCs, motor vehicle collisions, account for more than roughly 50% of all the injuries sustained by pregnant females. Falls account for many traumatic injuries due to the change in the center of the female's gravity. Violence, which this case was, 4 to 17% of women physically abused during their pregnancy. Penetrating trauma, so this is the true one, accounts for 36% of maternal mortality. And I think we did hear back from the flight crew that the patient did make it, so that was great. Luckily, that patient, again, she did not have any penetrating trauma to the abdomen, but if there were, then there would be a fetal fatality rate of roughly 67%. Severity of an injury and the outcome is dependent on the age of the patient, the gestational age of the fetus, mechanism of injury, and the severity of the trauma. The most common complication is premature labor and the onset of labor contractions. In trauma, it is a common response for a baby to attempt to sacrifice the pregnancy to stay alive. Abortion, traumatic injuries can cause spontaneous abortion before the 20th week, and abrupto placenta can be caused by blunt trauma. Pelvic fractures. When treating your patients for traumatic injuries, especially when they're pregnant, you want to go and watch out for shock. If the shock is not treated, it will then go and lead into cardiac arrest. Obviously, you got to keep within your ABCs and your spinal precautions. Backboard is going to be on the left side for this pregnant patient. Anticipate some bombing. Always have your suction available. Have your proper treat the hypotension and transport to a facility that has OB